Dr. McGuire.
Thank you. Thank you, Brian, and thank you, everyone. It's always an honor to have the opportunity to present at the AAP annual meeting. I think Dr. Williams has done his usual elegant job at bringing us up to speed on where we are with the periosystemic connection, and I've learned a lot about inflammation as it relates to systemic health from Dr. Zarek. My job here as a clinician is to basically say, so what? What does the movement from an infection model to an inflammation model of disease change the way we treat our patients? Does it or should it change the way we do daily activities in our practice? And I can tell you, as I began this process, if I took a hard clinical stance and I looked at my practice, the answer was no. That this change of inflammation emphasis had really not changed the way that I treat my patients on a daily basis, the way I diagnose my patients, the way I maintain my patients. And of course, that begs the question, well, should it? And I can tell you that I've struggled with this question for almost 2 years since I accepted this speaking engagement. And over the last 6 to 8 months, as I've actively researched this topic in preparation for this, I probably have worked harder on this lecture than I have anything in recent past, because really this isn't my area. Unlike the two gentlemen preceding me, I'm not an expert on inflammation, and I'm certainly not going to stand up here and talk to you about CRP levels, IL-1, IL-6, TNF-alpha levels. I'll admit I didn't even understand all of the things that the previous two speakers talked about. But I don't think as clinicians we really have to understand the molecular level of inflammation. I think as a clinician I can recognize inflammation in my patients. I think when I do the things I've been taught as a diagnostician and as a clinician, I'm pretty good at resolving inflammation. I think on most of my patients the outcome's fairly good. But our job as a clinician is to try to synthesize, try to translate all this research and bring it into practice. So what I'm prepared to do with you this morning is just simply to share my journey with you over the last 6 to 8 months as I have re-looked at the literature on inflammation, as I have talked to experts on inflammation across the world to see whether or not maybe I've missed something. Maybe there's something I should be doing different in my practice today than I've done in the past. Note I said I should be. At the end of the day, you're going to have to decide, should you be making any different decisions? Now, as I began this process of re-looking at inflammation, I have now a better understanding why so many of the experts on inflammation say, hey, forget the bacteria, control, or even better yet, prevent inflammation. This problem of out-of-control inflammation seems to be the engine that's driving the ever-growing list of chronic systemic diseases. And the problem of inflammation's friendly fire and systemic consequences is nowhere better illustrated than in chronic periodontitis, where we have a bacterial assault, but at least 2/3 of the tissue destruction is mediated by the host response to the bacterial invader, and to make matters worse, it seems that somehow this can affect things systemically. So the question remains, how should our new knowledge about inflammation relate to the treatment of periodontitis patients today and in the future? Note how I've emphasized today. You know, the easy way for me to have kind of skirted this whole issue was for me to give you a lecture on the future. You can't hold my feet to the fire if I do that, because I could speculate on all sorts of things, and frankly the future is very bright as it comes to the control of inflammation as it may relate to the treatment of periodontitis, regeneration, and all sorts of things. But as a clinician, I didn't think that would really give me too much. You know, I want to look at what's going to be important when we return to our practices at the end of next week. So we'll talk a little bit about the future, but I want to very much try to ground our conversations this morning in what we know today. So I re-looked at the literature. I talked to experts on inflammation around the world, and I basically focused on the following questions. How should inflammation fit into risk assessment? Is there a way to identify hyperresponders, and if so, should these patients be treated differently in our practice? Should new knowledge about inflammation change routine clinical decision making? Yes, no, sometimes. How should we do that? Should we change our patient examination? Are there any diagnostic markers for inflammation that are ready for use today? Should we spend more time on review of systems in our medical history? Is there a greater role for drugs, either local or systemic, that modulate the inflammatory response in the treatment of periodontitis, either antimicrobial or anti-inflammatory agents? Same question as it relates to regenerative therapy. I don't want to just look at treatment of disease, but how about regeneration? Should new knowledge about inflammation change the way we maintain our patients? Is there a greater role for drugs, both local and systemic? And how about all those questionable teeth that we're maintaining? And finally, are periodontists at risk for not referring patients who have other chronic inflammatory conditions to physicians? So I looked at all those questions. I restudied the evidence, and you know, basically what I found at the end of the day was that it really still didn't change a lot of the things that I'm doing. That good periodontal therapy is good periodontal therapy, but it did make me think about a couple of things, and that's what I'm going to share with you. Well, let's go to our first question. How does inflammation fit into risk assessment? You know, I'm certain that you're just like me in that you really don't have any generic patients. Everybody in your practice responds differently to inflammation. Everybody in your practice responds different to therapy. It'd be nice if we had a way to differentiate how are these people going to respond. Are they going to have mild, moderate, or severe response as far as their inflammatory reaction to local etiologic factors? For example, this patient in my office, she has fairly severe local etiologic factors, but not much of an inflammatory response. It'd be nice for me to be able to predict that. On the other end of the spectrum is this young man. This is a 24-year-old young man who's in my practice who has severe aggressive periodontitis. You know, both the opportunity and the challenge to us is to be able to identify this person early so they can be referred to a periodontist, treated appropriately, and maintained. But unfortunately, the way we generally identify these people is when they're at this stage. Is there a way for us today to be able to determine that this is a hyperinflammatory, he has a pro-inflammatory phenotype? You know, as periodontists, we're taught to evaluate the outward signs of inflammation. You and I look at bleeding on probing, we look at tissue changes, when in reality we're really looking at vascular proliferation, edema, tissue fragility. We look at probing depths, attachment levels. Really, we're looking at surrogate markers for connective tissue changes in the inflammatory phase of the wound healing process. We're taught to correlate infection, inflammation, and clinical presentation as we look at our patients. But the problem is, these don't always correlate. For example, you can have infection with certain microbes that don't really give you a clinical sign of inflammation. Ichinella corrodens, for example, rarely will give you any signs clinically that you're having any inflammation. Now, you can look at it on the lab bench with biochemical markers and tell that, but it doesn't give the clinical presentation. So there's a missing piece to the puzzle here. That was certainly one of the take-home messages in our series of articles on prognosis that we wrote. That, you know, if you're looking at commonly taught clinical parameters, they're not very good at predicting prognosis or the survival of the teeth. And in fact, they're even worse predictors in severe disease. Why might that be? Well, because you're somehow not bringing the host into the evaluation. There are novel diagnostic tests that allow you to determine if the patient has an IL-1 genotype that will cause the patient to over-respond to plaque. But our studies and many other studies have shown that even that doesn't tell the whole story. But you know, that's not surprising, because if you look at all the genetics right now, genetic testing, that it's at an early stage. not only an early stage in development, but also an early stage with what do you do with the information once you have it. I think that's one of the things that all of us struggled with. Now, that doesn't mean it's not important. Certainly, genetics plays a big role in why some of us respond with a lot of inflammation to plaque and why others, the inflammation goes away fairly quickly. But it's a complex story, and probably it's going to involve 3 to 5 gene families. It's going to depend on what ethnic group you're in, and clinical expression will probably depend a lot on lifestyle decisions. But the European workshop concluded that to date there's no clear correlation between any gene polymorphism and clinical indicator of inflammation. Well, there are a few computerized systems that may be of use that help us quantify disease status and risk. It's not that they really allow us to pick up hyper-responders, but again, as I said a moment ago, one of the ways that we really have determined pro-inflammatory patients is the fact they don't respond to traditional therapy. So perhaps if we have computerized assessment tools, we'll be able to pick these patients up a little earlier and not have to wait till they've gone so far down the road of disease before we determine that this is not somebody that we're going to treat in a typical fashion. So to answer our question, is there a way to identify hyper-responders today in clinical practice? No. The future's bright. With genome assessment studies, we are going to have wonderful new diagnostic tools, I'm absolutely convinced. We're going to have relevant biomarkers that we can use with saliva, with oral fluids that are going to give us real-time assessments of our patients' inflammatory status, allow us to treat these patients appropriately and earlier. But when it comes to today, as far as diagnostics, there's nothing that we can use chairside. Well, if we're not going to change our diagnosis much, how about, is there a greater role for drugs, either local or systemic, that modulate the inflammatory response in the treatment of periodontitis? We've got tons of evidence out there saying that we treat these people pretty good. Traditional periodontal therapy is effective in mild to moderate cases. It's these folks that you and I can effectively treat and hold our heads up high. Treatment for these type of folks have really not changed over the last 30, 40 years. I treated this patient in my residency 30 years ago with root plane and scaling and improving home care, and I'd probably do it the very same way today. Periodontitis is a bacterial-induced inflammatory disease, and our treatment today continues to focus both in treatment and maintenance on microbial control. It's these folks that we have a problem with. We've already established that we still don't have a way to be able to identify them early. How about treatment? The good news is they only occur in a small subset of the population. The bad news is all the people that we can treat effectively are typically being held in the general practice. So we're not seeing the ones that we can treat easily nearly as much as we used to, and this group is becoming proportionally larger group of our disease treatment and our periodontal practices. Now, what do we know about treating these patients that have aggressive disease? We know that if you're going to treat these people, we have to center on all the 3 elements that are driving tissue destruction: bacterial infection, the inflammatory cascade, and the host response. There's some evidence to suggest that with aggressive periodontitis, you also have systemic inflammation. That if you have just the bacterial assault and no systemic inflammation, you're probably going to end up with mild to moderate disease. But if you have the bacterial infection and you have a systemic inflammation, there is a synergistic destruction that drives the disease further than it would otherwise. And with that's one of the reasons why we commonly see severe disease associated with other chronic inflammatory diseases: pancreatitis, osteoporosis, the whole list that Dr. Williams and Dr. Zarek have been talking about. And in order to treat these people effectively, we also may need to bring as much as we can under control the systemic inflammation. It's another reason why we have to treat these people aggressively, not only because of the severe disease, but also because of the systemic consequence of not treating the disease. Now, to manage the bacterial infection, we'll do that the way we have always traditionally done, and that's with debridement. But when you have patients that are overreacting with inflammation to the bacteria, perhaps we need to be more aggressive with our mechanical debridement and reduction of probing depths to reduce this entire bacterial load in the periodontal pocket and in the entire oral environment to make that patient more maintainable. And along with that, if they're not responding well, as generally these patients won't, we want to consider antimicrobial therapy as needed with subgingival or systemic antimicrobials. Now, we know that with mechanical debridement, we can greatly reduce the bacterial load in the oral environment. But if you look at repopulation kinetics, the bacteria comes back pretty quick. We know also if we will add to our mechanical debridement either local or systemic antibiotics, we may be more effective at maintaining that reduction in the bacterial load. And so especially with patients that have a systemic inflammation, the antibiotics may be important. You know, that's one of the things that Tanetti in his paper showed, that with root planing and scaling and locally applied antibiotics, they had a lower amount of systemic inflammation than they did just with the debridement itself. And then management of the host. Now, this is a sticking point because we've known for a long time that host plays a big role. You know, in my residency in the mid-70s, plaque was plaque and too much of it was bad. And from that we moved to kind of the bug of the month club where, you know, it was certain bacteria that was causing certain diseases. And after that we began to say, hey, you know, the host may be playing a role here. So we've known it for a long time, but the catch has been, how do you manage it? How can you control it? Many people have made great strides at doing just that. Dr. Williams and his group have shown that they can halt the progression of periodontitis with anti-inflammatory agents. Unfortunately, the drugs are almost worse than the disease, but proof of principle was there. Lauren Golub and his group coined the term host modulation in the 90s, and the work continues. If we look at the state-of-the-art summaries, what do we have? This comes from the European Federation State-of-the-Art Summary in 2005. Clinical trials have demonstrated the ability of non-steroidal anti-inflammatory drugs to slow periodontal disease progression. However, recently reported serious adverse events preclude the use of COX-2 inhibitors as adjuncts to periodontal treatment. Adjunctive use of subantimicrobial dose doxycycline to non-surgical periodontal therapy is beneficial to the management of periodontitis over 12 months. Controversial data exists on the effects of bisphosphonate administration as an adjunct to periodontal therapy, and evidence on modulation of other host mediators, including lipoxins, cytokines, nitric oxide synthesis, is limited to animal research, and they conclude, after validation in long-term clinical trials, adjunctive host modulation therapy may prove advantageous in the management of periodontal disease. Well, you know, maybe that's just what's going on the left side of the Atlantic. Maybe we have something more to manage the host in the United States. Well, let's look at the consensus statements of the AAP. Since destruction of the periodontium is believed to be due to the host response, it's logical to consider therapeutic approaches that modulate host response in addition to antimicrobial, antibacterial approaches in the management of chronic periodontitis. 3 potential approaches to host modulation have been considered: inhibitions of MMPs with antiproteinases, blocking production of pro-inflammatory cytokines and prostaglandins with anti-inflammatory agents, and inhibiting activation of osteoblasts with bone-sparing agents. And after a large systematic review, they conclude large multi-center trials are needed to evaluate the role of host-modulating agents in the treatment of periodontal disease. That sounds familiar. NSAIDs and bisphosphonate drugs may have potential adjunctive role in periodontal treatment, and the adjunctive use of subantimicrobial dose doxycycline with SRP is statistically more effective than SRP alone in reducing probing depth and achieving clinical attachment level gain. So it seems on both sides of the Atlantic that as of today, you and I don't have a lot we can do to modulate the host other than subantimicrobial dose doxycycline. So how are we going to treat these folks? Well, it's reasonable to consider short-term systemic antibiotic or host modulation along with aggressive mechanical debridement to help control inflammation in patients that don't respond to conventional therapy, that have severe disease, especially in the presence of other systemic inflammatory conditions, and who are smokers or poorly controlled diabetics with mild to moderate disease. As I consider these consensus statements and what we have today to treat our patients with aggressive periodontal disease and severe disease in presence of other chronic inflammatory disease, I have to ask myself, I wonder why, if the only thing that we have that's been shown to allow us to somewhat modulate the host is subantimicrobial dose doxycycline, why haven't we as a profession really embraced this? And as I did all of my reading on inflammation and tried to look at the medical literature as well as the dental literature, I can tell you our medical colleagues seem to be embracing this more than we are. Well, I don't know. There could be a number of reasons. Perhaps you're like me. I've used it, and I didn't really see too much of a difference, and I don't think many of my patients felt there was much of a difference. There could be a number of reasons for that. One is it could be it doesn't work, but there's so much evidence out there that it makes me wonder. It could be that 80–90% of our periodontal pockets are inactive at any one time, and maybe we're treating the wrong people. You're not going to see a positive change on inactive pockets anyway. Could be that compliance is an issue here. For this stuff to work, it takes a long time for connective tissue to turn over. Maybe our patients are really not taking it like they should, even though they're telling us they are. Or it could be that it is working, and we just don't have the chairside diagnostics to determine this. Rheumatologists have known for years that they can't look at outward signs of inflammation, redness, swelling, and know what's going on as far as connective tissue breakdown in the joints. So perhaps we can't either. Now, certainly in the future, we are probably going to have ways to be able to look at biomarkers, to make sure that our treatment is keeping these biomarkers low. But today, we don't have that. Unfortunately, there's lots of questions. We've come a long way from calculus irritating the gingiva, causing the disease, but there's still a lot we don't know. Fortunately, we may have drugs out there that are helping us treat these difficult-to-treat patients and not even know it. Ken Corman and I talked about this when we did our Vision 2020 lecture 3 or 4 years ago, that there are drugs and technologies being developed for systemic diseases that will treat and prevent periodontal diseases inadvertently. Perhaps the question shouldn't be who will be treating periodontitis in 210, 220. Is it going to be general dentists? Is it going to be hygienists? Perhaps the question is who's treating it today that we don't know about. Bisphosphonates slow the progression of periodontitis. Statins dramatically reduce bone loss. These drugs are being taken by millions and millions of individuals, and it has the potential to reduce the severity of periodontal disease before these patients ever reach our office. On top of that, there are drugs that are being developed that will be used to treat periodontitis intentionally. The most active drug development today is in oncology and inflammatory disease. It takes a tremendous amount of money and resources to get a new drug through the FDA. Periodontal market's not big enough to do that. But my friends, inflammation is inflammation, and the drug companies know that. And when you treat inflammation on one chronic inflammatory disease, it's going to have an effect on inflammatory periodontitis. I think this is an important kind of conceptual thing. It's a broader view of the periosystemic connection, that there are common critical pathways of multiple diseases, and you treat one and it's going to affect the other. And certainly we'll be seeing more and more of this in the future as well. Well, both the speakers touched on this. Also, when we're treating our patients in our office, are we also reducing systemic inflammatory diseases? I'd like to think we are. Probably a bit premature for that. But I think if we will focus as practitioners on treating inflammation and not infection, it really puts us where we want to be in the periosystemic connection, and that is that the mouth is connected to the rest of the body, regardless of what the outcomes really end up being. I do think there's compelling evidence that there are strong associations. You know, as was mentioned, we have 3 good studies showing that treatment of periodontitis improves endothelial function, reduces the chance of cardiovascular disease. We have good studies showing that treating our patients' periodontal disease makes glycemic control better. We're in a discovery phase here, and it's probably going to take another 10 years or so before we can determine, are there really strong connections? But what's the worst that can happen? We treat their periodontal disease. What if a connection's found? How will that affect your periodontal practice? Well, all of a sudden, you're going to be referred many more patients that have chronic inflammatory diseases. All of a sudden, medical protocols are going to include diagnosis and treatment of periodontal disease. But diagnosis and treatment by whom? You're going to have more collaboration with your physicians on treatment, patient care, research, but more collaboration also means more competition with oral surgeons on who is the go-to source for dental knowledge in the medical world. We're probably going to see physicians start to treat some forms of periodontitis. And if we're not better at managing and at least recognizing the systemic components, we could end up being a technician for the physicians in this. So it's not all positive. It will definitely change our profession dramatically if these connections are associated. And we need to be prepared for this. Well, if that is how we might change the treatment of our disease patients, how does inflammation affect our regenerative therapies? I mentioned that I was in my residency in the late 70s. I started in 1977. The year before I started, there was a very interesting article by Rosslin et al. In Journal of Clinical Perio in '76. He showed that after flap osseous surgery with no regeneration, that they got radiographic evidence of bone gain, of regeneration. I mean, this really stood our profession on its ear at this time. Now, there was a lot of people that says, hey, yeah, but this isn't real world, because you know what else they did? They brought these patients in every 2 weeks for 2 years to do home care instructions and prophylaxis. But I think they certainly showed that in an environment with little to no inflammation, that wonderful things happen. So perhaps we should be thinking about reducing the inflammation, concentrating on getting in an inflammation-free environment, and then adding our cytokine reservoirs, or then adding our growth factors. You know, inflammation is a strong mediator in the healing response. And look at my patient here, where I've gone in, you can see the large intrabony defect that we debrided. We grafted it with a growth factor, recombinant PDGF, and here at 2 years, you're seeing good radiographic evidence of the fill of the defect. At 3 years, even more consolidation, and even more impressive, we're seeing changes in positive radiographically in the furcation. So something's going on very wonderful here. But I also want to draw you attention to my preoperative view and postoperative view. See any inflammation there? Look at this is a 9mm probing depth. See any bleeding there? Inflammation may be extraordinarily important in our regenerative results. I mean, if you think about research right now, we can regenerate almost anything on a preclinical level. You know, using growth factors, signaling molecules, live cell therapies, you know, it's something. But have you ever thought about why we have difficulty and why we've not been able to show that we can grow bone with BMP around teeth? Maybe it doesn't work well in an environment of inflammation. The future's bright, though. There are all sorts of drugs that are out there that block the bone resorption pathway, that maintain bone once you have it. You do your regenerative procedure, now you give them this drug. It's to keep the bone. Animal research even shows that bone grows back spontaneously if you eliminate inflammation. All that's in the future, though. Well, how about this question? Should new knowledge about inflammation change the way we maintain our patients? I have to tell you that it is this question that's made me think more than any of the other questions about maybe changing the practice, my practice. Is there a greater role for drugs, both local and systemic, and how about those questionable teeth? You know, I have a large, mature maintenance practice. And I see this all the time, as I know you do. You have patients who have done very well over the years, and all of a sudden their disease reactivates. It's not because they've forgotten how to brush or floss. It's because as we grow older, we change. Changing may be a little more fat around the middle. Changing may be osteoarthritis or diabetes. All of these things alter the systemic inflammatory balance. And when we see a reactivation of the disease in our patients, it may mean that there is something going on systemically as far as inflammation that's allowing that to happen. And that these patients may be at more risk for problems outside the oral cavity as well. So we want to make sure that we don't take this lightly. That when our patient's disease reactivates, that we need to take this inflammation seriously, both because of local and systemic consequences. You know, there is emerging evidence by Steve Offenbacher and other people that bleeding on probing, bleeding scores may be good predictors on systemic inflammation and your chance of developing severe periodontitis. That if you have high bleeding scores, that's a good indicator of systemic inflammation. Low bleeding scores correlate with biomarkers for low systemic inflammation. And that we perhaps don't want to think of gingivitis as this innocuous thing that we thought of in the past. And that in our maintenance population, that if you have patients that are high risk, you know, smokers, diabetics, people who are not responding well to traditional periodontal therapy, and perhaps patients with other chronic inflammatory diseases, that you need to treat these people more aggressively if their disease begins to come back. You know, don't just decrease their interval for the maintenance. Don't just do more home care instructions, but you need to think about, let's make sure we've debrided these patients carefully. Let's make sure that we consider either local or systemic antibiotics. Let's make sure that we think about maybe toothpaste with anti-inflammatory agents, or we think about essential oils that we've known for 20 years that have anti-inflammatory abilities. Bottom line is, we may want to treat these people a little more aggressively than we have in the past. And here is really the sticking point of what's really got me thinking about my practice. You know, I doubt I'm the only person in this auditorium that has quite a few patients on my maintenance program that overall, you know, they're doing pretty good, but they may have, you know, a few teeth here, a few teeth there that just stay chronically inflamed, no matter what I do, no matter what they do. Maybe even a tooth that's basically hopeless. But, you know, the patient says, no, doc, it doesn't bother me. And because, frankly, I don't know what else to do, I've done it all. And because I think I'm doing the right thing by them to treat them conservatively, that I say, you know, as long as that tooth's not bothering you, and as long as we don't see that it's beginning to adversely affect the adjacent teeth, we'll just keep on doing like we're doing. I say that every day. I had a patient a few weeks ago that really drove this home and made me think. I mean, this guy is sitting in my chair. He tips 400 pounds. You know, I worry about my chair. So, you know, he's obesely overweight. He's high stress. He's a computer tech guy that is, you know, if you believe him, he's the most high-stress guy in the world. He has sleeping problems. He has a history of cardiovascular disease. He's diabetic. Now, he is compliant. He comes in every 2 to 3 months. But I'm thinking, are you crazy? You're maintaining these chronically inflamed teeth when he already has all these systemic markers of inflammation, and I'm adding to this? So it's making me rethink that perhaps in this situation, in patients that have other chronic inflammatory problems, that I should not be adding to that inflammatory load, and that either I need to go in and retreat this with newer technology than I had in the past, or I need to get these teeth out of there. Fairly reasonable studies suggesting that implants do well in patients who have had refractory periodontitis. You know, these are hyper-responders perhaps. We don't know why. Maybe the bacteria is different around implants, maybe because they don't have a PDL. But the bottom line, they do pretty well. The implants do well. Now, I don't want anybody to leave this lecture and say Mike McGuire is suggesting we go back to the focal infection theory and we start taking all these teeth out. That's not what I'm saying at all. I'm just saying that if you're like me, you know, we have this problem where we think retreatment is a personal failure. I think as a profession we need to get beyond this. I don't think our physician colleagues feel like this. And if we have areas in our patients with chronic inflammation, we either need to retreat them with newer technology or we need to face the facts that in this case the patient would be better off without these teeth. We also could do a better job at risk factor modification. This isn't anything new. You know, we've struggled with this for years with our patients. We have our traditional risk factors, our smoking, our plaque, our diabetes, the genetics. But also, as the two previous speakers have pointed out, there's a whole new list of risk factors that we maybe need to consider. Increased weight around the middle increases your inflammatory load. Poor sleeping patterns, same thing. High-fat diet, same thing. Not all of these have been studied as it relates to periodontal disease, but you know, these kind of things, all of these increase the systemic inflammatory load. And if we're going to try to tip the scale on our patients so that if we're doing a regenerative procedure, tip the scale to try to reduce the inflammation, then at least educating our patients about how all of this works together and about how they can make lifestyle decisions, lifestyle changes to reduce the total inflammatory load could have an impact on the outcome of our treatment. And then finally, are periodontists at risk for not referring periodontitis patients who have other chronic inflammatory conditions to physicians? You know, I thought of this because, you know, we as periodontists have knocked our general dental colleagues for a long time for not referring periodontitis patients early enough, for not diagnosing them appropriately. Are we at risk for this? Should we be taking a more detailed systems review during our patient exam? You know, we're realizing that the periodontium is part of a systemic stream of events, yet we're only monitoring a very small part of it that has systemic consequences. Well, I don't think, and none of the people I really would talk to think that there are markers that we can use to be looking at these, and that probably doing CRP levels and those kind of things are not appropriate. But, you know, could we be doing more in our medical histories to pick up these people? I think as a group, we periodontists probably have a more complex and more comprehensive medical history than our general dental colleagues. But if you're like me, you really don't do much of a systems review. Maybe at next year's AAP meeting, we should have a course on history and physical. Really, if you look at a lot of these things, trying to pick up the diabetic phenotype and the cardiovascular phenotype, most of these things can be evaluated just through questionnaire or visual evaluation. But it wouldn't kill us to occasionally take a fasting blood glucose level either. You know, people used to laugh at dentists taking blood pressures when they started. What are you doing taking a blood pressure? You're just a dentist. As was mentioned, the Scottsdale Project, I think, was a great first initiative to try to bring together physicians and dentists and periodontists to see how can we co-manage these patients. And while the evidence was maybe not strong enough to make strong guidelines, they came up with some things that I found useful. For example, they suggest that dentists may consider referring to a physician perio patients who've not had medical evaluation within 2 years, or two or more of the following: either greater than 50 years old, they're at risk for diabetes, they have hypertension, dyslipidemia with a family history of cardiovascular disease or stroke, that they're tobacco users, or a history consistent with cardiovascular disease. Well, what's the flip side? How are our physician colleagues doing out there? Dr. Zarg said that, they're not looking in the mouth too often, and if they do, they probably don't know what to do with it. Well, you and I are not going to teach them how to probe. That's kind of silly. And the American Academy of Periodontology, I can tell you, for many years have tried to reach out. We had a program a number of years ago where we tried to talk to some of the other medical associations and the medical auxiliary associations. And it basically fell on deaf ears because they wanted to know where the evidence is. Well, the evidence is getting stronger. It's not quite there, but it's getting stronger. And we certainly have the patient's interest. And that is driving it a whole nother direction because the patients are demanding these kind of things. But I think that we are moving in the right direction with this. And again, the Scottsdale Project suggested to the physician that they should ask the patient, have you seen a dental provider in the last year? If the answer is no, do it. If the answer is yes, then they suggested that the physician not go in and probe the patient, but simply ask these 3 questions. Do you have bleeding gums, unsteady teeth, or gum recession? And if so, they should be referred to the dentist. So I think we're getting a little better about at least reaching out, about all of us understanding the importance of inflammation. The American Academy of Periodontology is having a big conference on inflammation later this year, and the Scottsdale Project and all of these, it's all growing toward us trying to decide how can we work better for the betterment of the patients. So back to my initial question. Should the movement from an infection model to an inflammation model of disease change the way we treat our patients? And again, it really should be the way I treat my patients because I can't speak for you. I told you at the beginning of this that my answer was no, that I wasn't convinced that there was any reason for me to change. I can tell you after re-looking at the evidence, talking to experts around the world, that I think, yeah, it at least is making me think about treating a segment of my patients a little different than I have in the past. When I have patients who have aggressive periodontitis, or I have patients who have periodontitis in the presence of other chronic inflammatory diseases, I'm thinking, at least in my practice, that I should have a greater emphasis on inflammation and patient education. A lot of pluses to this. Certainly, this whole periosystemic thing is a great motivator for the patients to accept treatment. It seems to maybe be having some positive influence on third parties. And, this whole thing may also be a call to action for us to reclaim the treatment of periodontitis and say that just, ineffective treatment of periodontitis is just no longer going to be, something that we're going to accept. I'm thinking that I need to expand my medical history to include more systems review because currently there's no chairside diagnostics to identify these people. That perhaps by looking at a more intense systems review, that I can pick up some of these people. That I can then refer them to the physician, but also it will help me better understand how they're going to respond to my treatment. And if I can kind of push the inflammatory balance to a positive side, it may have a positive effect on my treatment. That I'm going to treat these folks more aggressively. If they're going to respond to plaque in a more exuberant fashion, then I can't take the wait-and-see approach. Now, note I'm not saying we're going to over-treat these people, saying we're going to treat them more aggressively. I'm going to consider short-term therapy with systemic antibiotics or host modulation to help control inflammation in these hyperinflammatory patients. I'm going to consider retaining fewer questionable teeth in this patient population for the reasons I've stated. I'm going to encourage risk factor modification And finally, I'm going to continue to develop relationships with physicians and create referral networks. I've done this for a long time, primarily with ear, nose, and throat physicians, because I want to develop a relationship with them so that they can look at any pathology that I pick up on my scans when I'm doing it prior to sinus lifts, but also I want to do it so if I ever have a problem and I send the patient back, the ear, nose, and throat guy has at least heard of a periodontist doing a sinus lift. I can tell you that they appreciate private pay patients, me referring them to them, just like you appreciate those. I think we can continue to expand this network of developing relationships with our physicians for our benefit and, most importantly, for our patients. So to conclude, I, like the other two speakers, look forward to having the opportunity to give this kind of lecture 5 or 10 years from now when we have more solid evidence to really pin our conclusions on. But as clinicians, we deal with areas of uncertainty every day, and we make our decisions on less than perfect evidence. And as the advocate for our patients' health, at least with this segment of the population, I'm going to err on more aggressive treatment, because under-treatment in this group of patients may result in more than just a loss of a few teeth. It's been our pleasure to spend this morning with you, and look forward to any questions that the group may have later. Thank you very much.